Well, hello, and thank you for inviting me to present at the Focused Ultrasound Foundation 8th International Symposium. I'd like to share with you some of the results that we've obtained while attempting to use low-intensity focused ultrasound as a potential intervention in patients with a disorder of consciousness. I should start by saying that I don't have disclosures, and these are the entities that so generously fund different aspects of this work. Now, when I refer to disorders of consciousness, I am talking about a set of related conditions typically acquired following traumatic or non-traumatic brain injury, such as coma, the vegetative state, and the minimally conscious state. And these are conditions that present a number of complexities to them. But in particular, there really aren't many therapeutic options for these patients. However, over the last 15 years, there has been an emerging understanding of these conditions as a dysfunction within a thalamostriato-pallido-thalamocortical mesocircuit. And so the idea is that the greater the dysfunction in this cortico-subcortical mesocircuit, the greater the impairment in these conditions, and also the greater the whole brain dysfunction, which you can see portrayed at the bottom of the slide. You can see a depiction of what metabolism as detected with FDG PET looks like in a healthy volunteer on the left, with hot colors representing a higher metabolism. And the next three images depict a typical minimally conscious state patient, vegetative state patient, and patient in a coma. And you can see the progressive depression in both global and in some areas local metabolism. Now, the beauty of having a neural network understanding of this approach is that it gives us targets. For example, thalamus is a target that has been looked at with other interventions, such as deep brain stimulation, which have shown promising results. But unfortunately, a recent clinical trial has shown that over 80% of patients in a disorder of consciousness, due to brain pathology, are not eligible to undergo DBS. So we're trying to replicate the DBS approach, but with focused ultrasound. Now, a few years ago, we initiated a first-in-human clinical trial. This was the very first example of applying this technology in the clinical context in this manner. And what we did is we recruited both acute and chronic patients in a disorder of consciousness. We did some standard clinical testing on the day before and the day of ultrasound. Then we did MR-guided ultrasound, and you can see here on the right an example of our transducer by the side of a T1 image of a brain. We administered ultrasound inside the MRI machine, and then we did again clinical testing after this and on the day after. And usually we would try to bring patients 1 week later for further testing. In terms of how we administered ultrasound, you can see depicted here the parameters. The key parameters are a 0.5 pulse width, a 100 hertz pulse repetition frequency, and a 5% duty cycle. And you can see portrayed down here the intensities that we're using. Also, the way in which we administer the ultrasound pulsation is in little blocks of 30 seconds, which means we administer 30 seconds of ultrasound, and then we have 30 seconds of a break, then 30 seconds of ultrasound, and 30 seconds of break, and so on and so forth. So this means that over 10 minutes, we administer 5 minutes of ultrasound, broken in these little 30-second blocks. Now, focusing on the acute cohort, and these were 11 patients, and then, like everybody, we got shut down by COVID. But in the first 11 patients, we had very clear clinical data. So this is just the best score that patients achieved before the ultrasound on this clinical assessment, which is known as the Coma Recovery Scale Revised. And then you can see the scores following ultrasound. And here we could detect a reliable increase in the scores, which means lesser impairment. Now, not only we see a clinical effect, but we actually saw changes during the MRI. Specifically, looking at thalamocortical connectivity, during the blocks of ultrasound, we could see a change in the thalamocortical connectivity portrayed here. So the areas that you see highlighted here are areas for which the thalamocortical connectivity is changed during the ultrasound compared to periods when the ultrasound was not administered. On top of that, we also see that the degree to which the thalamocortical connectivity is changed in the areas that you see portrayed here is actually predictive of how much patients will recover in the clinical scores over the next week. So not only we're seeing the effects of ultrasound on connectivity, but we're actually seeing that there's a connection between how much the connectivity is changed and how much patients recover in the following week. Looking at the chronic cohort, which also we could only collect 10 before we got stopped, we can see exactly the same trend of clinical results. Again, a statistically significant result, even with such a low sample. So on the basis of these initial feasibility results, we launched a new clinical trial where we really wanted to get a good understanding of two things: the unfolding in time of the clinical effect, and a better understanding of what happens from a biological point of view, what happens to well-characterized biomarkers that are well known to be associated with depth of impairment in disorders of consciousness. So in this new clinical trial, which is ongoing, we first bring patients to our facility in Pomona at Casa Colina. And we first do an extensive baseline over 4 days. So we do multiple clinical assessments, a couple electroencephalography recordings, PET, and we collect one MRI. After this, we administer focused ultrasound, and in fact, we administer double the dose that we administered in the first trial. So we administer 10 minutes of ultrasound over 20 minutes. But we do this at the bedside, as you can see here. So here you can see two members of my group administering ultrasound, and instead of being inside the MRI, the MR guidance is done with a frameless stereotactic device, which you can see portrayed on the right side. And then, following this administration, we follow up for the next 6 days with additional clinical electroencephalography, positron emission tomography assessments. Again, for the sake of time, I will really focus on two things: the clinical results and PET, just because PET is really the hallmark, a hallmark biomarker in these patients. Taking the best score that a patient could achieve before compared to after, once again, we see exactly the same result, even just in our first 11 patients. Again, a statistically robust result, even just with this small sample. So at this point, we have just about total 30 patients worth of data showing these clinical effects. What is interesting is that if you look at the unfolding of the effect over time, we see two important things. So you can see here, so there's the baseline, then we administer ultrasound, the vertical line, and then we see two things. First, we see a clear depression in behavior in the patient, which we had observed also in the initial trial. But there we had only it was just an incidental finding. So we see for the first 24 to 48 hours, our patients look like they're more tired and less responsive. And then in the next 48 hours, we typically see an increase in their behavior and an increase in the frequency of their behaviors. So we see this bimodal, this initial dip, and then we see patients perform better than before. What is interesting is that if you look at PET, and we look both at thalamus and full brain, in thalamus, we first see a light decrease consistent with our behavioral data, a light decrease in the metabolism, and then a meaningful increase. And we see exactly the same pattern at the full brain level. So this is really connecting what we see in the clinic to what we see with these biomarkers. So let me just close by saying that overall, in terms of safety, we've had no SAEs. We've had a few adverse events, but they were all related to the procedure, not to ultrasound itself. For example, we've seen a lot of UTIs typically connected with positron emission tomography. In terms of effectiveness, we do see some initial effectiveness, both in the acute and in the chronic cohort. And we start seeing some evidence for a mechanistic link between what we're doing with the ultrasound and the effects that we're observing clinically. Of course, I have to stress this is all done open label. So our next step, once we have completed data acquisition for this clinical trial, is definitely a randomized, double-blind, sham-controlled clinical trial so that we can really start looking at these effect sizes. And with this, thank you very much for your attention.